Thank you for the kind invitation. First slide, I kept that I am behind enemy lines, but I changed that at the last iteration. What's the topic today? I will be talking about how big is the problem and why the problem is even bigger in our region and the cause of the problem. How big is the problem? The problem is massive. Coronary heart disease and ischemic heart disease is the main cause of death in Australia. It's causing 20-25% in death in the US and rising and continues to be the highest cause of death in European countries. It kills around 18 million people per year. This is almost double what cancer is killing, and it's 10 times what diabetes is killing as well. Out of those 18 million, almost half is caused by ischemic heart disease, some caused by stroke, some a little bit caused by peripheral vascular disease. For the past 2 minutes, there's 34 patients actually died from cardiovascular disease. And if we go historically, like when I was a medical student, tuberculosis was up high in the list. It became an 8th killer, the 8th number in the killer list in 2002. In 2030, it's expected to be rank 23. Where ischemic heart disease was number 1 back in 1990, is still number 1 in 2002, and still going to continue to be number 1 in 2030. So you're all going to be in business, don't worry about that. So the problem is even bigger in our countries. If we look at the mortalities in our region, Kuwait mortality for coronary disease for ischemic heart disease is 47%. So it's count for 47% of our death. Saudi Arabia is similar, 45%. Oman is a bit higher, 49%. The rest of the Gulf also share same numbers, maybe the lowest in Bahrain, but it's not far away. If we dissect what's happening in country like Emirates, 40% of the death caused by cardiovascular disease. If we combine all non-communicable diseases together except cancer, this will be an equivalent. Out of this 40%, 60% is caused by ischemic heart disease, and the rest caused by stroke and other cardiovascular diseases. The problem in our countries, which is a huge even burden, that they present in even younger age. In Gulf area, the presentation, I think we all agree as cardiologists and interventional cardiologists and the surgeon, that we are facing patients who are age 20, 30, and 40, and the mean age in the Gulf is 58, which is 10 years younger than what American colleagues are, and almost 15 years younger than what European patient would be, and 10 years younger than Australian as well. Which put us in a problem: PCI first, CABG first, what should we do? And this gets in a dilemma because the patient will be our patient for a long period of time. It's not a one visit. Why is that? Because we have all of those. I've been in so many TV programs, so many radio station programs as well talking about risk factors. We have them all in the Gulf. We have the non-modifiable and modifiable. Aging, back in 1990, Saudi Arabia, life expectancy was 65 years. Currently, life expectancy in Saudi Arabia is 75, and in some Gulf countries is more than 80. Family history, we share the same gene pool, and they are have a lot of genes that related to dyslipidemia as well as cancer, as well as ischemic heart disease. Modifiable causes, I think we don't need to speak much about food. Omani halwa, Bahraini halwa, and Saudi food and Kuwaiti food and Qatari food or Emirates food are as well not much to talk about. We all know that we have very heterogenic diets. We also have epidemic blood pressure as well, and I will talk about the other risk factors. Speaking of diabetes, for example, if we take the whole population, 15% of Kuwaitis do have diabetes. And in 2030, it's projected to be 22%. And if we talk about patients above the age of 50, we're reaching 40% of the population will be diabetic. If we look at the prevalence of diabetes in age of more than 40, in the region, you look at the top countries are in the bottom. Saudi Arabia, Oman, Kuwait, Bahrain, Emirates, and Qatar is not in the list, and that's why it's not in the, it's actually, sorry, in 16.7 as well prevalence. So all the top 5 are actually from the Gulf areas. Why is that? Because we also have an epidemic overweight and obesity in this region. If you compare European countries, the obese people usually are, this is an overweight actually, people are 10 to 20% of men and 10, 20%, 25% for women. If we compare Oman or Bahrain or Qatar or Saudi Arabia, almost all of them are double that. So we have a very high prevalence of obesity and very high prevalence of overweight. Moreover, if we're going to cover dyslipidemia, lipids out of 9 modifiable causes for myocardial infarction, lipids still have the highest attribution risk comparing to everything. Even if you add smoking to diabetes altogether, they will be equivalent to lipids by itself. And we have a very good relation showing that there is a very high relation between ischemic heart disease and how high is your LDL. The higher the LDL, the higher risk of you having an MI. We have no reason to believe otherwise. We also know that by reducing your LDL by 1 millimole, you would reduce your risk of any major risk events by 20% and any MI by 20%. So just 1 millimole reduction. How is the world is doing? Not great. In the US, 50%, and this is for secondary prevention. We're not talking about primary prevention. So those are even sicker patients, and they are under treatment. 50% of the US patients are being treated. Only 39, 35, and 34% of the European countries are well controlled. UK, only 23% of the patients are being controlled. And this is not a great job. In our region, we have also our study that shows that 75% of the patients who had MI, they are not in targets. And 88% of the patients who have they had actually an MI, they are only in a statin, so they have a lot of room of improvement, yet we are not controlling them. And this is a study which is the Gulf Action study, which was done over 3,000 patients, also replicated that again, showed that the 75% of our patients are not being controlled, even though they have a free medical system, they have privilege to all kind of medication available for free. So with all of this, I would conclude is that we have a huge problem that's causing both lives and financial burden at very early age. And the risk factor modification should be implemented not by doctors only, by policymaker region-wide to control the disease. Thank you.